Okay, so I'm delighted to be with you. I'm here, my actual capacity is as a trainer for the the UK Research Integrity Office. I'm a retired moral and political philosopher, but I've got about 30 odd years worth of experience in research ethics, but most notably, more than 20 years in NHS. I'm not going to go through all my background and so on, but I suppose the most interesting thing is that I also chair Google DeepMind's Human Behavioural Research Ethics Committee. Can't tell you lots about that because I'd have to have you killed. I don't know how many non-disclosure agreements and so on that I've signed, but the work is pretty well as you might imagine. Just to clarify right at the outset, the best way is to always say NHS and social care, or health and social care. This has become even more important recently because of the reorganisation of the NHS into integrated care services, where the mission is to try and bring NHS and social care together. But having said that, in terms of ethical management and regulation, the two have been together for a very long time. Okay, so just by way of introduction, I'm going to go back and recall an experience I had. It was somewhere between 15 and 20 years ago, very long time ago anyway. And a colleague at the university, a mathematician, came to see me with a plan. They'd partnered with the local NHS trust, and the idea was to use mathematical modelling using patient data. Now, the data were just about everything that could be readily collected and recorded and thrown into a database. As every patient was admitted, all of their observations were put in place, just general data, as much as could be provided. And the idea was to use those data to develop things like early warning systems. This was obviously in the very early days of use of technology, but I could readily see how, if they got enough data together and the right algorithms in place, the right systems in place, it would be possible for ward staff, to be alerted on admission or on subsequent taking of observations whether a patient was significantly at risk. Very crude, very simple idea, but then my imagination started wandering, and I said to my colleague, well, surely if you get enough data, you'll eventually be able to decide who's worth treating. So the ethical issues come to mind immediately. And as I say, this was years ago. So I said, it might be that at some point you feed in a patient's data and some sort of magic system, and all I could do was use my imagination at the time, will say, this one's a dud. Now, I'm being terribly crude with the language that I'm using, but that was the sort of discussion at the time. This one, there is no point in doing anything which is particularly invasive or heroic in any way. This person, according to the data we've got, is already on the way out. Well, it's then obvious how ethics comes in terms of use of data and so on. That work has actually continued, and it is now in the form of an NHS approved database, which means that obviously those data can be accessed for other studies, but they can also be accessed or provided to researchers who need those sorts of data sets and so on. There are all sorts of problems around managing confidentiality and anonymity and everything else. But like many data sets, this one now has got a technical solution so that any identifiers disappear before the data are available to local researchers, or indeed the research, or indeed anybody external that wants to use those data. So over a very long period of time, that work has continued. I think, so the big ethics issue for me was its use for prediction. There was no intention to do that at the time. And actually, there is still no intention to do that because, ethically, it's highly problematic. But at the end of the day, I still puzzle and think, would I rather rely on strong technology or clinicians trying to remember from their experience? And a lot of the time, I would say guesswork. That, again, is probably being unkind, but there is the potential there to do something, I think, really, really helpfully. The NHS is constantly overburdened. And I'm not going to get into the politics of that, even though it's interesting. It cannot continue to treat as many people as it does treat. A lot of my time recently has been tied up with COVID vaccine research. I've reviewed all of the Oxford AstraZeneca studies within my NHS Ethics Committee. And so, not surprisingly, I've gained a lot of experience about the management of COVID and so on. It seems to me obvious that some people are going to be admitted to hospital with COVID, and some it could be determined at a very early stage whether or not treatment would be successful. And of course, everybody's disinclined to go down this road. Also, because of my COVID interests, I belong to lots of clinical ethics committees. And those ethics committees have spent lots of time trying to work out how to prioritize patients using very crude sort of ethical analyses and trying to work out systems and so on, trying to work out what criteria might be used for prioritization. Well, actually, the solution is there, or could be there, with a lot of caution. But I would very strongly hesitate to suggest such a technological solution. So you can see where I'm coming from with all of this, and I think it immediately puts the ethical issues right to the fore. So moving on, if you look at the use of health and social care data, I think there are two extreme positions. There's one which says researchers should have maximum access. Now, what lies behind that is valuing the interests of the community beyond those of the individual. So there will be lots of circumstances where we can say, if we can benefit a community by using data, gaining access to data and using it to develop systems, then surely that's a good thing. That's one extreme. And the other extreme, of course, is where the rights and priorities of individuals seem to outweigh those of communities. So when it was first mooted that our personal GP data would be shared, there was pretty well an outcry shared with researchers. And it didn't take long before NHS Digital had to put in place an opt-out so that people could, if they wished, opt out of having their personal data, well, their healthcare data shared for the purposes of research. There's not a massive number of people that have opted out, but certainly there were lots of activist pressure groups and so on. So if you go down the maximum sharing route, it's obvious that there could be huge benefits. I won't go through all that list. I'll pick more of them up later, but the benefits are really quite staggering to the community as a whole. If, on the other hand, you go down the other route, where what seems to have to dominate is my individual privacy, and my individual consent to everything and so on, there is a case for it, because we don't want risks of breaches and so on. We don't want misuse of data, things like insurance and similar issues. We need to avoid all of those things, but there's got to be some sort of balance. Otherwise, broader society is going to be a loser here. I think that a balance is developing over time, and I'll try and pursue that theme as I go through. Interestingly, one of the questions was, how can we get people to trust us? When actually, you're going to use data for the public good, for good overall. But if people are distrusting, then it's going to be very difficult to see that way forward. Now, I'm going to throw in a bit about COVID here, because I think, and this is a personal opinion, but I think it's led to greater distrust in terms of the use of data. And not least things like the way COVID data are broadcast pretty well daily. You never get the data you actually want. I'd like, when I hear the numbers of people who have contracted contracted COVID on the basis that they've had a positive test in the last 28 days, that's useless data. Because actually what I want to know is who or how many actually died from COVID, or who actually got admitted to hospital as a result of COVID. Instead, I get useless data. Now, Joe Public isn't stupid. They come to the same conclusions as me. And when I find out how many have died, I want to know some demography. I want to know their ages. I want to know whether they had underlying conditions, and the stories go on. And then you get as far as the parliamentary, the political broadcasts, because I think they are political, and the scary graphs. And then people again begin to say, look, this makes no sense. This is not much short of guesswork. These are crude extrapolations, or they're mathematical models produced by people with a very shady history in their success with modeling. So the whole thing builds up more and more. And then I think that then in turn leads people to mistrust the use of data. And then, of course, you've got all of this stuff in the background with a test and trace program, the NHS app, many people, and I'm amongst them, who is very reluctant to use things like those apps because, I might be being paranoid, but there is this issue of, can I be tracked and traced? What is actually going on here? Then the passports and so on. So I think trust, if anything, has been harmed by the use of data in COVID. So what about sources of data? When you're thinking about your projects, your studies, quite clearly, there's lots of publicly accessible data out there, accessed by just simple searches, using usual search engines and so on. Nothing very exciting. But of course, the danger with data of that nature, or data sets of that nature, is that the quality is always going to be questionable. Alternatively, you can look at data which is accessed through regulated sources, such as the NHS, and I'll say a few more words about NHS Digital later. Academic sources, these days, research grants nearly always come with the caveat that data has ultimately to be shareable. At one time, when I was first started in NHS ethics and wider aspects, the normal practice was, as soon as a study was finished, you got rid of all the data because they're confidential and all the rest of it. These days, facilities have to be made to share them, and of course charities. and here I'm thinking particularly about patient support organisations. There are loads around: diabetes, multiple sclerosis, Parkinson's. All of those organisations hold data. So data sets which are accessed through regulated sources, they need quite a lot of governance support behind them, because they invariably require data sharing agreements and so on. But those are going to be reliable and hopefully useful. Of course, you can go down the original data route, and you can do that through minimally regulated sources. So you can conduct research using social media. There are loads of ethical issues around social media, issues of consent and so on. I've not put it on the slide, but if anybody wants more advice and support, look at BPS, British Psychological Society guidance. There is a recently republished version of their guidance on internet mediated research, which is really useful. Or you could take the technical option. These days, lots of data sets are algorithmically generated. The figure that I got in terms of the most recent sets of data is that about 19% are algorithmically generated. So there is no obvious human involvement, but still very, very useful research. Or, of course, you could get original data through regulated sources. So in the NHS, you might go as far as setting up your own database, or any wider research in the NHS will obviously be regulated. Turning to the issue of anonymisation, because that is always the big one. Now, anonymisation is not a good in itself, and I think that researchers are increasingly of the misguided opinion that anonymizing everything is A, required, and B, a good. It's not. I mean, it's very convenient because it saves lots of legal issues, but actually, in many ways, turning to the other side of an ethical argument, it is actually quite disrespectful, because, you know, my identity is actually quite important to me, and I'm sure it's to you as well. I don't want to have my identity change from David Carpenter to participant 1, 2, 3, 4. I would much rather stay as David Carpenter, because I think that's the most respectful position. But, you know, that's not always practically possible. So whilst anonymisation avoids obvious harms in terms of confidentiality and things like that, it also results in missed opportunities to do good. Now, manipulating any data will inevitably bring about results which might be of value to the data subject. If you've completely anonymized everything, there is no chance of returning any potentially valuable information to a data subject. And I think that's highly problematic. So just running through these bullets fairly quickly, I'll leave you to look at the detail. The use of completely anonymized data doesn't even normally require HRA, NHS ethics review, because if the data are completely anonymous, then it's seen as no particular ethical issues arise. So any data sets that are completely anonymous, then there are no difficulties. There may be a need for data sharing agreements. There may be a need for other governance issues, like getting approval. Now, NHS approval is different to NHS ethics. NHS approval is all about making sure that all of the legal issues and so on have been solved. You use the same application process, but it's just the case that an NHS ethics review isn't needed. So there are absolutely no GDPR considerations. If the data are completely anonymous, there's no GDPR considerations, nor is there any need for consent. It's not possible. It may well be the case that assurance has been given that the data have been provided with previous consent before anonymisation, but there is no immediate concerns. The same is true or similar with pseudonymized data. This is the difference, of course, is that with pseudonymized data, it is at least technically possible to link the data to the data subject. And actually, most NHS data are in this category. What happens with data from NHS Digital is that in most cases, the data will still hold the subject's NHS number. Now that means there won't be an immediate GDPR concern there, because you haven't got names, addresses, dates of birth, and all the rest of it. But because a link is there, then it still counts as identifiable data. Now, that's not a problem, because eventually, most researchers don't need the NHS numbers. They will get them, but they don't need them. And most researchers are not going to make any attempt to go back and try and connect. But if a researcher were to find something of interest to the data subject, they can at least go back to the data source and say, give the number and share anything that might be of interest, which seems to me to be ethically important. The normal issue is that any personally identifiable data, and here I am talking about names, addresses, and so on, can only be provided with consent, the consent of the data subject. Now, that's got nothing to do with GDPR. GDPR does not normally use consent as the legal basis for processing data. In a typical university, it will be a task in the public interest, which actually means that researchers are pretty free to do what they like with even personally identifiable data. But that needs to be contrasted with confidential identifiable data. And here I'm thinking about patient records. So if you want direct access to patient records, you will need their consent. It's as simple as that. And lots of studies are like that. The only way to access identifiable confidential medical records is with the approval of the Confidentiality Advisory Group. This is a bit like an ethics committee, and it meets in much the same way as an NHS ethics committee, and it decides whether the researcher's request is a valid and reasonable one. Now, working with huge data sets, which just happen to be identifiable at the outset, with no particular risks and so on, is something that can be fairly readily approved. So where formal NHS application has to be made, the normal process is through IRAS. And one of the first things to think about is the filters at the beginning of IRAS. There are two filters that are largely relevant to you: limited to working with data, and notice that says specific project only. So that's data for a specific project, as it says on the tin, which is rather different to setting up a research database, where what you're going to do is collect data perhaps around a particular issue, perhaps a particular condition, perhaps a particular situation, and that database is then used for further research. The huge advantage of NHS research databases is that, again, they can often or not be used subsequently after approval the approval then becomes a generic approval, so that anybody who applies to use those data, as long as they follow the rubric of the generic approval, then no further ethics review will be required. For nearly all databases, there is a sort of an access committee that looks at requests and decides whether they're bona fide or not. In the background is, and this is the most important part of policy, is the UK policy framework for health and social care research. I've put the link up there. It's not actually terribly long. The biggest issue is looking at two questions. Firstly, is the project research? And there are definitions provided within this framework. But the big thing in the NHS is that it excludes other data collecting activities. So audits, service evaluations, and various other things. The question as far as ethics review is concerned is that it must be research. And secondly, does it involve NHS patients or their relatives or carers? Involve includes using their data. So if neither of those conditions apply and you're getting your data from elsewhere or you're conducting your research outside of the NHS, then there are no particular concerns. Lots of researchers will go directly to, for example, to a charity and gain the access there, or use other sources. That's the main framework. Within the framework is a list of ethical and practical principles. Obviously, I'm not going to read all the way through these, but I will pick out one or two. These days, any research in the NHS requires a PPI, participant and public engagement. And I said PPI there, you can see where that comes from, PPE. Anyway, it requires engagement. So the expectation is, if it's practicable, that participants are involved in research all the way from design to dissemination, and ideally as co-researchers. The other thing that I pick out is that is the importance of a good protocol. There is always an expectation that there's a protocol there. I think there's always a danger in universities and other institutions to see the ethics application form as almost the protocol, and it shouldn't be. If you go through the NHS, the two are quite separate. What you put in the IRAS form and what is actually in the research protocol. Well, as I said, I'm not going to go through all those, but they are all to be considered if you're making an application for an NHS ethics review through IRAS. So moving on to some of the more substantive areas, NHS Digital, it's essentially the repository of all of our GP data. And obviously, it can be used to access data. Now, as I said earlier, people can opt out. So if you make a request through NHS Digital, then the data you receive back will obviously already be cleaned. It won't include the people who've opted out. It will still include what under data protection legislation we would call sensitive data. That sort of thing doesn't get sieved out. It will be identifiable through NHS numbers, so that will still be there. So it will be truly anonymous, but for GDPR purposes it will be pseudonymous because the link is in theory there. The other areas that it doesn't include is anything which is legally regulated. So we're talking about data about terminations of pregnancy, data about sexually transmitted diseases. So even though that might be in the GP record, it won't actually be in the data set, because legally, by statute, that can't actually be shared. So there's the standard opt-out. As I say, it came fairly quickly after the plans to share GP data came out, because there was a massive public outcry. I will just say a few words about that. I don't understand it. You know, and actually, if most people reason enough, does it matter to me if my anonymous data are shared for research purposes? As long as I've got all the appropriate reassurances that I'm not going to be identified, but because, you know, that is really important. There are no risks to things like insurances and all of that sort of stuff. There's no risks to my employment, and with all of those assurances, why would anybody really worry? I mean, I just think maybe the case hasn't been made strongly enough to say how valuable data are in terms of the future health of everybody. And as soon as people begin to understand that, I would hope that not many people would see any objection. But nevertheless, it's there. There's lots of activist groups. There's lots of people that are trying to regulate this even more strongly than it already is. So there are obvious problems, but I think there's a lot more we could do, and there's a lot more the NHS could do to say, you know, we provide the treatment, and if only we could share as much of your data as possible, other people could benefit from it. NIHR is the sort of research wing of the NHS. So NIHR actually provides funding, but it also provides data. And most significantly, it provides patient cohort data. Now, moving on from that, part of NIHR is CPRD. Again, I'm going to leave you to read through the detail, but what I want to go on to say is CPRD does also provide cohort data. And I think cohort data are particularly valuable. Here's an example of one, which is supported through NIHR. It runs out of Bradford. And this is a huge database of people who are living relatively independent, who are 75 years and older. And it is really just a database showing this cohort. Now, those cohort studies, obviously you have a cohort study which sets up the cohort, which need not necessarily include any specific research. The cohort is just valuable in itself as a source of data. And then you have the opportunities for researchers to engage with the custodians of cohort studies and then extend that into further research. So I strongly commend the use of accessing data from cohorts. I mean, the idea has been around for many, many years. When I was a child, I don't think I quite maybe even before, we had the 7-Up study, which was a national study following a small group of young people through their lives. And so there's incredible amounts of really useful data. What about AI and the NHS? Well, the NHS has got an AI Ethics Initiative, and it's recognized the value of embedding technology in the NHS. So here's the initiative. And again, have a look and see what the NHS is doing with AI. There's a very nice report, which was reported 2 years ago. And in that report, there is a lot about governance and AI, some of the thornier issues. Again, well worth looking at. The value of AI is really quite considerable. And this report highlights the value of AI and broader technology in health and social care. Diagnostics, well, that's all fairly obvious. There have been amazing developments in things like image recognition. You know, images are very easily managed in terms of their value for diagnostic purposes. So the projects that are around are things like using AI for interpretation of mammograms. There's a huge amount in and around ophthalmology. So some of the most difficult to diagnose ophthalmic conditions, if you've got enough images, you can actually do some amazing things. You know, symptom checkers, things like risk stratification, what I was hinting at right at the beginning. You know, we should be able to use data to calculate risks rather than, I think, the more human-based mathematical models. There's room to do a lot more. Drug discovery, really important. It's possible to link together loads of different drugs and work out the optimum use for those drugs, possibly development of new drugs and so on. Well, again, I won't go through all of these, but pick out just one or two. Knowledge of rare diseases. Rare diseases are very, very difficult to research. If you can use as much data as are available and apply technological solutions or interpretations, then we can advance or make advances in rare diseases. Public health, obvious. Think about system efficiency. Right back to where I started, where I said, you know, the NHS is likely to end up on its knees. I'm not seeing much technological solutions to these problems. So even simple things like working out staffing requirements, at the moment, it's largely through human endeavour, when actually there is room for much, much more application of technology. Then the so-called P4 medicine, a developing field, but a really interesting one. P4 medicine means using or being conscious of prediction, very helpful, prevention, and again, there is scope to use much more technology in the prevention of ill health, but more broadly. Personalized, the next P. So it means that there can be technological solutions to managing things like, well, pharmacogenetics is probably the best example. It's increasingly recognized that drugs, you know, well, the efficacy of drugs very much depends on the genetic makeup of the individual. Trying to get genetic data and pharmacological data together can be incredibly valuable. And the other P is participatory. So the idea is that patients should be participating in these endeavors. So as much as we can see the value, there are still the challenges. We have to think about key things like transparency, accountability, liability. You can see the list, and the risk of bias and so on. All of those risks are there, and they need to be carefully thought through when looking at the ethics of using AI. So recently, the NHS set up the AI Lab and sent out invitations for bids for £140 million worth of money for innovative projects. And that actually has resulted in some amazing projects. Now, obviously, I'm not going to read all these through, but there are 4, and they were announced only a couple of weeks ago. So this stuff is really very current. The University of Westminster's project on setting up a chatbot largely aimed at people from ethnic minorities in and around HIV and sexually transmitted infections. Now, you think about the value of a chatbot rather than the embarrassment of human interaction. It could be incredibly valuable, and it could get to groups which are less, well, are more reluctant rather to use direct NHS facilities and talk to people face to face. Loughborough, a project looking at adverse maternity incidents. Now, the thing about maternity incidents is that they don't necessarily follow obvious patterns. There needs to be lots of interrogation. You know, why do some hospitals, and there's been a lot of publicity about this lately, have incredibly high perinatal mortality rates? What is actually going on? Where you need a damn good study to begin to look at this in much more detail. So that's Loughborough's gift. St George's, this is with Moorfields. You've probably heard on the radio, I think it's Specsavers that offers these wonderful examinations where they're looking for things like macular degenerative disease and also diabetic changes and so on. There's been a lot of work, and this goes back, I think DeepMind was largely involved in this. There were so many of these scans that it was impossible for Moorfields to process them, because Moorfields actually had the human skills to look at the scans and see if there were any concerns. But it became increasingly commercialized, and the only solution was an AI one. Well, what's happening in St George's is that they're taking it forward to focus more on diabetic scans. And finally, Birmingham, here, really importantly, they're looking at better ways of regulating data sets. So, you know, there's huge developments only 3 weeks ago. And I think I'm going to stop there and see what questions we've got. I mean, as far as I can see, those conscience prompts, I don't want to dismiss this, but most of them are fairly commonsensical. You know, and particularly with NHS research, if people apply through the standard IRAS system, there is a whole set of questions about processing data and the nature of data and so on, which I think, you know, by going through those questions, you can pretty well see what has to be done. And again, coming back, it's really important to, wherever possible, work with anonymous data, or if not, pseudonymous data. You know, I'm not sure that there are huge problems in those circumstances. And there's no reason, there's no reason why for research in and talking to you all in your sorts of fields that you need to have data which, you know, where there are significant risks. You know, you can work with the data without having the, you know, without having identifiers on them. I don't know. I mean, I know that there are concerns, management concerns, but I'm not sure that there are real concerns in the real world if simple rules are followed. And I think that's pretty well all I can say. I mean, there was another related question where somebody asked, how do you keep the integrity of the data in the anonymization process? Well, the anonymization process is literally the removal of identifiers. The data should stay robust enough, even if you've got named data that you eventually anonymize, but the data should still be sound. Well, of course there is. I mean, hacking is obviously more difficult to avoid. Yeah, I mean, and data hacking, particularly in universities at the moment, is really quite a problem, because there are lots of organizations that seem to be using ransomware and targeting universities. And if they use ransomware, you don't know how far they've got in terms of hacking personal data. But leaks, if they are, well, obviously one would hope that leaks aren't intentional, but any leaks obviously have to be reported through eventually the Data Commissioner's office. So they have to be fessed up to, and obviously any reasonable steps that that can be taken to avoid harms from those data leaks have to be put in place. But we're seeing this much more broadly than in healthcare. Data leaks are almost a daily problem, and all you can do is to have your systems as robust as possible to try and make sure they don't happen. The answer there, and actually I do quite a lot of ethics review involving rare diseases. People with rare diseases are typically losers because they're not part of big data sets and so on. And even if you've got, and there are drug companies that are quite happy to develop new drugs for people with rare diseases, but actually trying to get NICE to license them, those drugs, that they could be used, is really difficult indeed. So it actually requires quite a lot of quality of life type qualitative research to be able to make strong cases to support people with rare diseases. Now, that sort of research is obviously much more, well, you probably wouldn't want to anonymize it. Now, it comes back to my point about anonymization. It's not a requirement to anonymize. You can actually get people's consent to name them and to, which again, I come back and say that is still distinct from GDPR, but people's consent to name them, to involve them, and, on an ethics basis, thank them, respect them, acknowledge them. So the answer with rare diseases is to actually be far more open. There are most rare diseases, there are groups, there are patient support groups, and those patient support groups are usually very, very happy to act at least as gatekeepers so that researchers can actually get in touch with the patients themselves. Yeah, well, I'm certainly not seeing it as binary. There is always room for that insight that the clinician can bring, which is really important. There's a huge amount of room for that intuition that the clinician might have, and for at least testing that. Now, I don't think it excludes a technological approach. In fact, we do need both, because sometimes I'm quite sure the technological answer is going to be counterintuitive to the clinician. And we certainly need clinicians there who are going to still follow their own intuitions. I don't see a problem with that. So I don't think that it's mutually exclusive, and there is room for both, but there's also practicalities. I mean, the retinal images that I spoke about on a couple of occasions, there is no way that you could actually process those through human beings. There's just far too much data. It's impossible. So I suppose what I'm saying is there's room for both. And I wouldn't want to see the value of intuition degraded in any way. Perhaps the best example of how technology is improved upon individual clinicians' ideas is it probably in areas like oncology, where using or finding the right cytotoxic drug for many years was largely a matter of physician intuition and, you know, physician choice, often not terribly well guided. Now, with all of the work that has gone into developing various chemotherapeutic agents, you know, that has improved endlessly. I'm glad we've passed the days when it's the clinician that thinks, well, I tried that last week on so-and-so, and develops from there. Well, I mean, certainly I would highlight the work of NHSX, because that seems to be its major driver at the moment. And positively, at least in terms of research, COVID has shown so many mysteries that need to be understood. You know, why are people from Black and ethnic minorities so much more prone? Why do they seem to suffer far more and more likely to catch COVID and all the rest of it? We haven't got answers to that. But I mean, coming back to the point about funding, this comes up fairly regularly. The HRA, the Health Research Authority, is very clear that researchers are not doing enough to seek funding for the right things. So to seek funding to make sure that that big example, that all research is, as far as possible, without bias and is not discriminatory, but it needs to be wider than that. If you're going to, I mean, there's this urge to involve patients and participants in research from the beginning. Well, there are costs attached to that, but even very simple things, like most researchers don't cost in things like strategies to disseminate results to the patient group. They think it finishes at the Lancet publication. And many don't factor in the costs of ethics review, or indeed the costs of research governance more broadly, particularly if those costs have to be borne within a university. You know, ethics review costs money, governance costs money. It all has to be built into a bid. But increasingly, it seems that funders are seeing requests for funding for those more important areas, as we would see it, as an indication of good quality research, rather than, you know, somebody trying to screw a bit more out of the system, to put it bluntly. So look at what's coming up in NHSX and look at the huge thrust to try and provide something which is far better for people from ethnic minorities. So thanks for your questions. Thanks for your participation.